Hello all and welcome to the Caregiver Support Series.
Hey everyone, Sarah here. Let's all do one thing together quickly. Take a nice big breath to your comfort level and exhale. I want you to keep in mind as I'm talking how much of a privilege that is. Breathing changes at the end of life are unfortunately common and often the most distressing to patients and loved ones. Breathing changes happen for a lot of reasons, so today we will explore what to expect when someone is declining towards the end of life. So sit back with your favorite hot beverage, and as always, feel free to reach out. I will use words to describe to review breathing changes at the end of life. In the education corner, I will touch on treatment options for shortness of breath and give you one of my most valuable nurse tips ever. Our next episode is being taken over by Amber Black, one of Hospice of Northwest Ohio's inpatient nurses. Amber will be talking about caring for a loved one with Alzheimer's disease. Breathing changes happen for so many reasons. Of course, people who are suffering from chronic lung diseases, such as lung cancer or COPD, experience shortness of breath. But changes within the function of the heart, the brain, the kidneys, and almost every other major organ in the body can spark breathing changes. Breathing changes can include, but are not limited to, periods of rapid breathing, periods of no breathing at all, noisy breathing, or excessive coughing. Someone may describe their shortness of breath as tightness, pressure, or heaviness in the chest, feeling smothered or suffocated. They feel like they need to sit up because lying flat makes it worse, or maybe a choking sensation. There are so many different ways that this feeling rears its ugly head. And there are several types of breathing patterns. While it's important to recognize these, it's most important to recognize whether or not the patient is in distress. Remember, someone can appear very short of breath and feel fine, or appear to feel fine and be very short of breath. The best indicator of shortness of breath is the patient's report. But if they're unconscious or unable to verbalize that feeling, there are signs to look for. You don't need to know the names of specific breathing patterns in order to recognize distress. I could get all scientific and explain Shane Stokes, Biot's, or Kussmaul's respirations to you, but what it really comes down to is noticing changes in the rate, meaning how many breaths per minute are taken, and the rhythm, or a regular or irregular pattern of breathing. A normal respiratory rate is around 12 to 18 breaths per minute in a consistent, easy pattern. At the end of life, people may suddenly start to breathe very fast or very deep, very shallow, or very irregular. And that's fine as long as they aren't showing signs of distress. Those breathing changes are expected and normal and routinely do not cause distress, but if they do, they should be treated immediately. Signs of distress include, but again are not limited to, a furrowing of the eyebrow, restlessness in the body, muscular tension, maybe a frown. If at any point you are uncertain, you can always call. The treatment plan for shortness of breath is so easy once you determine the cause of shortness of breath. That is where the mystery lies. Is it tumor growth? A pleural effusion, which is fluid around the lungs? A pulmonary embolus, which is a blood clot that has traveled to the lungs? An upper airway obstruction? An infection like pneumonia or COVID? Is it a pneumothorax, known as a collapsed lung? Superior vena cava syndrome? A myocardial infarction, which is a heart attack? Is it asthma or an allergic reaction to something? Congestive heart failure can cause shortness of breath, so can anxiety, abdominal distension from a bowel obstruction. The cause determines the treatment. Shortness of breath can be treated with procedures, steroids, with narcotics, with aerosol treatments, chemotherapy, sometimes with counseling, dialysis with diuretics, a chest tube, sometimes with antidepressant or anti-anxiety medications, radiation, antibiotics, surgery. See my point? The cause needs to be determined before the treatment. That's why a nurse or a doctor needs to thoroughly assess your loved one, no matter what point they're at in their disease process. So, of course, the first step is to try and fix the underlying cause. There are certain times when that's not possible, so the next step is considering medical treatment. Oxygen can be helpful, but does not always solve the problem of shortness of breath. There are also non-medical interventions you can try. I've done something as simple as pointing a fan in a patient's face to relieve their shortness of breath. That feeling of circulating air can make a huge difference. Sometimes they just need reposition to sit up straighter in bed in order to take a better, deeper breath. One thing that in general people don't understand is that opioid narcotics such as morphine are not just for pain. Narcotics are significantly better than oxygen in reducing shortness of breath in terminally ill patients. This is because narcotics dilate and relax blood vessels, which decreases the amount of oxygen needed and alters that feeling of shortness of breath in the brain. When used appropriately and safely, narcotics can bring the patient relief from shortness of breath without sedating them. The bottom line is a professional, a trained healthcare clinician is needed to determine the cause and treatment of shortness of breath. When I was working in the ICU and a patient was taken off of all of the life support machines and expected to die, one of the first things I would do, aside from providing emotional support to loved ones, of course, is to explain to the family that I'm going to keep the patient on the least amount of monitoring equipment that I can. I would turn off the monitors in the room, but still be able to see the numbers at my spot at the nurse's station. That way, the family would concentrate on their loved one and not stare at the monitors. I've seen patients' heart rates jump and their blood pressure skyrocket when they hear a certain voice. So I know in my heart that the sense of hearing stays intact until the end, which means it's so important to keep the environment of the actively dying as peaceful and familiar as possible. Keep familiar voices around whenever possible. Play familiar, relaxing music or TV. If the patient had a particular favorite scent, for example, an avid rose gardener or someone who loved lavender essential oil, try and make it available. My point is, death should not be medicalized. It's a spiritual, emotional process. No one should be looking at the numbers. They don't matter at this point. Be present, be loving, be peaceful. Concentrate on creating a peaceful environment for your loved one, and peaceful means something different to everyone. Thanks for watching. This has been an episode of the Caregiver Support Series brought to you by Hospice of Northwest Ohio. Next week's topic is caring for a loved one with Alzheimer's disease.